Sorry about that.
Okay. We also are obligated to make sure they get dental care. They need to have a checkup every 6 months, like non-custodial youth are supposed to have, but often don't have. So that has to happen. Now, we monitor that with all of our regional health nurses. There are 15 regional health nurses. Is that correct, Mary Catherine? I always forget.
14
regional health nurses. Remember, there are 12 regions in the state. A couple of regions have 2 nurses just because of size, and 2 regions have 1 nurse because just of size. But if you think about the fact that we have over 9,000 children in our custody, there's no way that 14 nurses can keep track of every single thing for those youth. Getting these medical exams done, dental exams done, is the obligation of the families, the child's case manager, the FSW, family services worker. And then the forms are supposed to come to us, and the nurses review them and make sure that see if the child needs any additional care or follow-up. But there's no way with this staff that we can know the details of every child. Did they have their well child check at age 7, for instance? We might not have that. Mary Catherine and her supervisor, the director of nursing, Patty Slade, help the regional nurses making sure that with any struggles, any problems. And then I am their backup. Is that the right word? I don't know. I'm the supervising physician. So I handle questions and problems and all sorts of things.
You're a knowledge sponge.
I do a little bit of teaching. I like to teach. Let's see, I was going to say something. We have a very, very close partnership with TennCare, and specifically with TennCare Select, which is a special program within Blue Cross, which is one of the managed care organizations for TennCare for the state of Tennessee. All of our foster youth who are eligible are enrolled in TennCare Select. They're immediately eligible as soon as they come into custody. A few kids do have private insurance that they had through their parents that continues. And then some kids are not documented. And when I say not documented, I don't just mean they came to the United States without permission or approval for their immigration, but sometimes we have kids who are born at home and never registered in any way, shape, or form. So those kids are also undocumented. And until a child has a birth certificate and a social security number, they are not eligible for TennCare Select. But we have a payment process for medical needs. But we do have a very, very close partnership with TennCare Select to make sure our kids are getting the medical care and mental health care that they need as much as possible. I will say that there's not a day goes by that I don't have contact with somebody with TennCare Select or TennCare, the larger organization. And several days, like the past few days, I spend most of my days on the phone or in meetings with managed care organizations, but we do have a very, very close partnership. And I think here in the state of Tennessee, us specifically in DCS, are very, very lucky to have that relationship. Just a little bit about me. I am a child abuse pediatrician. So I used to evaluate children when there were concerns about child abuse or neglect. And I did that in person for 25 years. I was at Vanderbilt from 2010 until 2020 when I made the move over here to DCS. So I am, it feels like still new, even though it's been 2 years, but there's so much to learn here in the agency and in state government in general. So we do, as many of you know, we do get children in our custody with special healthcare needs. Sometimes those needs are known before the child comes into custody. Sometimes there's a reason a child comes into custody because the family is unable to care for that child because of their special healthcare needs. And sometimes the child develops special healthcare needs while they're in our custody. We do have policies and procedures and tracking mechanism for those youth. And our DCS nurses keep special track of those kids. They're way more hands-on with those kids because they need it. Mary Catherine did send in the policy, but I will tell you, we're very actively trying to change the policy and kind of update it to be a little bit more reflective of some of the children we've been seeing. In my view, every single child in state's custody should be called, medically fragile or a child with a special health care need, just by definition of the fact that they were removed because of abuse or neglect. But obviously we can't do that. But we also need to recognize there's a difference between a stable type 1 diabetic, a teenager who can care for themselves, versus a 3-year-old or 10-year-old or infant, whatever, who is has a trach and is on a vent and G-tube fed and needs total care. Those kids both have special health care needs, but their needs are obviously very, very different. Mary Catherine, what am I forgetting?
Well, I think you pretty much covered it. How we get that is we assess that. Sometimes the FSWs will give us the referrals. People, a lot of times they don't know when the kids come into custody, and they'll call us and ask us, for our opinion on it. Sometimes the hospitals will call. So that's kind of the way we get the referrals that come in. But most of the time the kids are in custody, and we find out about it through, like what she said, when we're doing our evaluations for EPSDT or well-being, or we get a call from the FSWs asking us, what do you think about this child? And when the calls come in, then we just assess the medical needs, the whole situation, what's going on, and that's how we determine and start following them from there. And like she said, we can't follow every child. So there's a process for those that are not followed by us. We do review their EPSDTs when they come in. We do review every psych medicine that comes through. And if we see something that's coming that's unusual, we get calls. We'll get called, and people will call us and let us know. But we do, that's kind of how we look at the whole picture for all the different regions.
Gotcha.
We say with this children with special health care needs, the DCS nurses stay in close contact with the custodian or foster parent or whatever, and do site visits with the child, and stays in close contact with the medical professionals caring for that child.
Gotcha. You ran through this at the very beginning of when you started talking, but it was pretty quick, and unfortunately I missed that on the recording. But say a child was to enter state custody and seemingly they didn't have any kind of special health needs. So just like a child who's presenting as healthy, based on their age level, what are they legally entitled to in terms of medical care, dental care, vision care, like the bare bones kind of what our volunteers can expect and look forward to make sure that they're getting in a timely manner?
I think that's a really good question. I think I'd like to change the word legally entitled to what we require and we want, and they should have. Every child in custody needs to have EPSDTs or well child checks when they come in, and then at least annually. For kids under 3, they need to have it according to what we call the periodicity schedule that the American Academy of Pediatrics recommends. So, the infant checkups and shots and toddler checkups. They also are supposed to start seeing a dentist at about 12 months of age, sooner if they need it. But once they start seeing a dentist, they're supposed to have dental care every 6 months.
Gotcha. Does that happen with their primary care provider, or is that separate?
That's a great question too. The vision evaluation and hearing evaluation are part of EPSDTs.
Can you break down that acronym? Sorry.
Okay, early periodic screening, diagnosis, and treatment. That's a Medicare, Medicaid term, a CMS term. And basically, I don't think we should use, I think we just say well child check. But there are certain specific requirements for that, and it includes vision and hearing check as appropriate for the child's age. Now, if a screening check, so let's say a 5-year-old reading the E and the stuff on the wall, if they fail that, then we refer them on to an eye doctor. That's why when the EPSDT forms all come into DCS, the DCS nurse in that region looks at every form. And if there's any finding, then we make sure that child has the appropriate follow-up. I just was reviewing some EPSDT forms recently, and a couple of kids failed their hearing screen at the health department. So we're going to send them to audiology to get a full hearing evaluation. And depending on that finding, we might have to refer them to ENT or whatever.
Gotcha. I have some questions, but I'm wondering if our volunteers have them. You can feel free to unmute yourself and jump in, guys. So I probably should have done this at the beginning. I'm not sure how familiar you are with our program, Dr. Lowen, but our volunteers essentially advocate for kids in state custody, and they attend all of the CFTMs and foster care review board meetings. And so they look to see if, these doctor visits are happening as they should. And if they're not, then it's our job to kind of bug FSWs about that kind of thing. And so that's why I thought that this information would be really relevant for our folks to hear.
And I forgot to say, in the past, DCS's policy was to have the children have their EPSDTs, their well child screenings, done at local health departments, except in areas where local health departments could not do them. A couple years ago, the state health department recognized that that's not ideal for kids. And also I came in and always thought that that was not ideal. Children should get their medical care in their medical home with their primary care provider. So I changed the DCS policy so that EPSDT or well child checks can and ideally should be done by the primary care provider. Now, some of these kids, when they come in, they're placed outside of the area or placed in a different region. They don't have access to their primary care provider. And then so 10 Care will help either help them choose a different provider in the new area or assign them to one. Occasionally, we still do have to use the health department if there's no primary care provider yet identified or accessible. But I do really believe that they get better care in general from their primary care provider's office.
All right, we have something in the comments. In Texas, I believe kids who, and actually the person that made this chat is a doctor, volunteer on my caseload. In Texas, I believe kids who come into foster care are required to be evaluated by a medical professional within a certain amount of time, I believe within 3 days or a week. Is there a similar requirement in Tennessee? I believe you alluded to this earlier.
Yeah, I said it earlier, but I will be happy to repeat it. Yes, within 72 hours of coming into custody, every child has to have a medical screening examination. Within 30 days of coming into custody, they have to have an EPSDT or a well child check. That first exam within those first 3 days can be that well child check or EPSDT to cover for that first month. So don't worry about missing it, Dr. Nguyen. So yes, they are required. That is very, very clear requirement.
Does that always happen?
Ideally, it should. Does it always happen in the best way? Probably not. Occasionally it doesn't, especially if a child is moving around a lot, like has a lot of placement changes within that first month. Let's say they were in a respite home or in this home or that home for a first couple of weeks, and then they get placed in a facility, a congregate care facility, like a treatment facility, a residential treatment facility. Sometimes a treatment facility thinks, oh, they've already been in care for a couple of weeks. We don't need to really get on this. We have a month. They might not understand. So it should always be happening, but occasionally it doesn't.
Is there any requirement, say a child, there's allegations of sexual abuse. Is there any requirement for the timeliness of getting like a forensic interview happening?
There are no specific requirements. And one reason, because we can't control when we can get a kid in for an FI. because they're usually done at CACs. So, you know, there are I'm not in charge of investigations, but obviously I'm a child abuse doc and I work closely with the people who do the investigations. So if a child comes into custody, or they're investigating a sexual abuse allegation that meets criteria for forensic interview, or the SIPIT team that decides that child needs an FI, I always push, especially if it's a younger child, get it done as soon as possible. Because I don't want any contamination. I don't want the child to forget some, you know, any important details, et cetera. But it really depends on where they are, who's doing the investigation, how old the child is, all those things.
Gotcha. Guys, I'm just going to keep asking questions if you don't have them, so please jump in. Well, selfishly, I'm going to ask you some specific questions about kids I work with. I work with a teenager who's refusing to take his medication for his mental health issues. Thoughts on that?
It happens, and it's a mess. You know, we don't hold teenagers down, you know, to take their meds. No one's going to hold a teenager down to take their meds.
That's basically what the foster parent said. I can't hold him down. And
No,
so
it's
that's
true.
kind of where we're at.
I mean, that situation would need a really good therapist. I hope that child's has a good therapist, is getting good, very appropriate therapy to determine why. And also, you know, it has had a good evaluation to determine, is the medication truly needed? Also, the prescriber needs to know that so that they might be able to, you know, if the child's denying the med or refusing to take the meds because they don't like the taste or they don't like a side effect, those are easily fixed. Now, sometimes kids don't verbalize that well, so you need a good prescriber who can ask the right questions.
Gotcha. In this instance, the child is kind of saying like, there's nothing wrong with me. I don't need to take these. So, but yeah, sort of a specific question. We work with a lot of children who are undocumented and don't have TN care, and it's super challenging to try to get them services. We recommend, you know, in the ways that we can, connecting them with places like Siloam. I think there's yesterday, Sherry, we were made aware of another program where, what's the name of it? Sherry, do you remember? It's in like Goodlettsville. And
Yeah, let me check real quick. I'll get back.
yeah.
I'll tell you, we do have a way for DCS to use our funds to pay for medical care. There's a specific form that needs to be filled out by the FSW, but we will pay providers to see those children.
And yeah, I think that, so just to give an anecdote, there's a child and he has significant mental health issues and is prescribed a medication that's very, very expensive without TN care. So the caseworker has to submit a PSG for our newer volunteers. I think that stands for payment for services and goods. And it's something that FSWs have to submit from time to time when they're trying to get a good. And so this FSW has to do this every month. And then we have to wait for it to process. And then that time, that child's not getting the medication that they need, which exacerbates the behaviors in the child. And it's actually caused placements to disrupt. Is that common? Should there be this big lapse? Does this have to happen every month?
It should not at all. I would want the FSW to reach out to their regional nurse who can then reach out. We have people in my division who actually work. They're very, very gifted at finding different ways of getting medication, getting services, and getting paid, you know, getting the right payment. But there should not be a lapse like that. A piece is missing with that. But I would advise the FSW to contact their regional nurse like as soon as possible.
Okay, that's helpful. Thank you. Megan
Sarah,
said,
Sarah, I dropped the name of that clinic in the chat box.
okay, thank you.
I was going to ask you all, do you have the link for the federally qualified health services centers in the area that service Tennessee? They're great. That's a great resource. We call them all the time. I'll send it to you.
I'm not aware of it. So yeah, if you could send it, that would be great.
Okay.
What are your thoughts on kids taking breaks from ADHD medication during the summer? Ooh, says someone who works in schools. For example, coming off of Focalin, I'm not pronouncing that right, while not in school.
Yeah, this has been talked about in the pediatric community for decades, actually. I think it depends a lot on the child, and it depends a lot on what they're supposed to be doing. And sometimes it depends on the parent, honestly. I will tell you, I'll out myself. My daughter has ADD. It is very clear her level of function when she takes it versus when she doesn't. I don't give it to her on weekends, or she doesn't take it on weekends. And during the summer, she doesn't really take it. But also, I'm very attuned to my kid, and she is getting more attuned to herself. And if we have something that she needs to really focus on, she'll take it. Like we had to pack her up for her 4-week summer camp. And, you know, packing for 4 weeks when you only do laundry once is a lot. And, you know, she's 14 and a half going on 35 in her mind. So she doesn't need help from her mom, but she can't get anything done because she's got ADD. So there might have been a little tension in my house that week, just saying. And she just wasn't getting stuff done. And I said, hey, do you think maybe you should take your med today? Would that maybe help? You know, I can't tell her because she's 14 and a half. And she said, huh. So she took it, and she was a new kid. And she saw it, but she's learning herself, like I would be helped if I do that. Now for the younger kids, they don't have that self-awareness. I don't think there's nothing wrong with going off unless it's going to impair that child's functioning to a point that they're not going to be able to function in doing what they are supposed to be doing. A recommended age for starting meds, there's no specific one age. We try not to, pediatricians in general, try not to start it before age 5, but occasionally you got a 4-year-old who needs it. But they also, you know, they need to be evaluated very carefully to determine why. And it depends when it impairs. I mean, it's not like kids develop ADD. They often had it, but the symptoms weren't bad enough to interfere with whatever they're supposed to be doing. But a really important point is a lot of our custodial youth who are in custody for a reason, despite what the media might say, we don't go just picking up kids and, you know, wanting to add them to our caseload. They're in custody for a reason. And sometimes trauma will look like ADD or ADHD, or even living in a chaotic home. And our child is not getting enough sleep, and our dad's beating up mom or whatever. That will look and act very much like ADD in school, especially in school. So I do get angry when I see a doctor who's prescribed ADD for a kid or diagnosed or ADD meds and diagnosed it without even asking anything about, tell us about home. What's going on? And especially for custodial youth, I want to know, you know, have they had an evaluation? Are they okay? You know, do they need counseling to deal with the trauma they've experienced? Question is, if they're on a psychotropic drug, they need but to be seeing doctor for checking on doses. Yes, but we don't have specific timelines that we require. Any prescriber who is halfway decent should be following up with that child on a routine basis, whatever they deem is appropriate, given the type of med, how long they've been on it, if there's labs that they need to check, but then follow up with that youth. But we don't dictate how frequently that follow-up needs to be. I was, with one caveat, I'm covering as a doc for one of our treatment facilities, sort of treatment facility, and the psychotropic med prescriber routinely says, I'll follow up in 3 months. Now, these youth are in a facility for a reason, and they often have very significant behavioral issues. To me, 3 months is too long. So it's on my to-do list actually to talk with him and say, maybe a little bit more frequently, please.
Had a question. Is counseling and trauma therapy something that is addressed outside of regular medical care?
Yes, it should be. Most practices don't address that routinely in a regular pediatrician's or FP's office. So ideally, it should be if it's felt to be needed. In my ideal world, every single child in custody would be in counseling or receiving some type of trauma-informed therapy. The truth is that there's not even nearly enough therapists for the kids who are having obvious problems.
Yeah, I would second and third that 100%.
Does TennCare, it is covered. I'm not sure if it's covered by TennCare or by us. Mary Catherine, do you know, for counseling?
It's covered by us.
That's what I thought.
I don't think it's necessarily covered. Some of it's covered by TennCare Select, but they do have specifications.
You know what it is? I remember now. We are actually a managed care organization for behavioral health care needs. So we cover it, but we get money from the feds for that.
Why can't you get, this is a volunteer and a foster parent asking this question. Why can't you get meds refilled out of state for kids on TennCare? Asking as a foster parent trying to take my son on vacation and not being able to refill one of his prescriptions while we're out of town and not being able to refill it because of insurance.
It depends on whether the pharmacy will accept, the out-of-state pharmacy will accept TennCare. And the vast majority of them don't. So it's and same thing if you need medical care, if you have a child out of state, or if they go on an ICPC, you know, at out of state placement, we have to find providers and pharmacists that will accept TennCare, and sometimes that's a challenge. I will say that Optum, which is our pharmacy, the pharmacy vendor through TennCare, they're pretty good to work with. And if you're going out of state and have problems and need a supply of meds or need meds sent to you, we can often make that happen, right, Mary Catherine?
Yes, they're very good to deal with.
Yeah,
Excellent.
and yeah, so Ms. Bennett, if you are going out of state and you're going to run out of meds while you're gone, contact your DCS nurse and we can work with Optum with you.
And that information would be in the reminder email that I sent you guys, that attachment that Mary Catherine sent. These are great questions. Does anyone else want to jump in?
I have a couple of questions, Dr. Lowen. You spoke earlier about, no one's going to, pin down a teenager and make them take medication. Just wondering if you could speak to, is there a magic age when teenagers can refuse medication or refuse medical treatment?
When they're 16, they can consent for their own psychotropic meds and psychiatric care. They can certainly refuse treatment then, but honestly, if you got a 13 or 14-year-old who's a big kid and is not going to take his meds, there's really not much you can do about it. Again, that's when you got to work with the prescriber on getting a med that the youth will consent to take. If they're just adamant, there's really not much you can do. And even if you take that child to the hospital, no hospital is going to hold down a fully competent, a 14-year-old who's functioning like a 14-year-old to administer medication. They're just not going to do it.
What about in a medical crisis situation where an emergency room visit is probably warranted and the child is refusing to be transported or be seen?
I think it will depend a lot on what the emergency is. Sorry, I'm not trying to be evasive, but some people's perception of emergency is not what a medical emergency is, or, obviously if the child's a danger to themselves or others, that's going to be different because that child's going to be involuntarily held. And police might need to be involved, and in the hospital emergency department, they might need to be shackled. Or restrained is a better word. Police might shackle, but restrained. So it's going to be very variable.
That's okay. I'm a social worker, so my favorite answer is it depends.
Okay, good. So I'm not trying to be evasive. I'm just,
No.
it depends.
Yeah, absolutely. And I had one other question about the need for a child or youth to be seen by a medical professional if they've come off of runaway status, especially if there are concerns about trafficking.
Yes, they are. They have to be seen if they've been gone more than, was it 24 or 48 hours? I can't remember.
I think it's 48, but I can't remember right off the top of my head.
It's one of those 24 or 4, if they've been gone more than 24 or 48 hours, they have to get a medical evaluation. If they're concerned about trafficking, they have to have a full evaluation, including testing for STIs.
Emily, Ann, I see your question, but before we go there, I say you were working with teenagers that you suspect are sexually active. How can we have a conversation about contraceptives or depot or anything like that? What age can we go there?
Well, I don't know if it's your job or it should be the medical practice, the practitioner's job. Well, let me say this. Let me change that. In pediatrics, we are taught to start talking to kids alone outside of the presence of a guardian or parent pretty early, like 11 or 12, to ask those questions. And as far as you guys, I don't know the exact rules, but I think it is appropriate to talk about it once they hit the teen years. However, you have to be comfortable doing it. And you have to be able to do it without any judgment coming out in the way you ask the questions, in your facial expression, in anything. That's hard for people. I mean, it is truly hard. But and that's why if you can't do that, that's fine. Don't leave it. Let somebody else do it. But if you do feel comfortable, just make sure you ask very open-ended questions, very generic questions. You know, do you have, when you talk about, are you in a relationship? You don't say, do you have a boyfriend or girlfriend? Are you intimate with, are you, or you could say, do you have a boyfriend or girlfriend? Just like that, assume one or the other. When you talk about, intimate contact, you just say, hey, you don't have to use the word intimate contact, but are you engaged in any sexual behavior, activity, but in a very, very open-ended, calm, non-judgmental way. And you have to be willing to be able to hear what they say without any horrified facial expressions. Because if they are comfortable opening up to you, that's awesome. But the first sign that you're uncomfortable with what they're saying or what they're doing, they're going to clam up and not going to open up to you again about it.
At what age would DCS consider potentially prescribing birth control pills?
Remember, DCS doesn't prescribe. It's the provider. It's a medical provider.
So what age would the provider? So say we knew that a 12-year-old was sexually active.
Well, the provider's got to ask the right questions because 12-year-old is below the age of consent. So they're not allowed to consent to any sexual activity. But if it's 13-year-old, which you are allowed to consent, then the partner has to be within 4 years or else it's a rape. But there are reasons to prescribe birth control. And it doesn't have to be the pill, there's other methods, but that's a conversation between the youth and the medical provider. That is not, the FSW should have nothing to do with that conversation. The DCS nurse should have nothing to do with the conversation unless help is needed to understand things.
Right.
Gotcha.
We do not have those conversations. We refer them to the medical providers because they're the experts. They've got the child there. And then they also have the FSW is usually taking them or the parents are taking them, and they have that relationship so that they make sure that the parents are involved.
Gotcha. We had a request to hear some success stories that you personally cling to on those tough days that you encounter at DCS.
Mary Catherine?
Oh, I got a good one. This is my baby. I got his picture on Mother's Day. When I first came to DCS, I got a call from Vanderbilt, and went up to see this little boy. And he was, they had taken him into custody. The parents, it was a drug case. The baby had been exposed to everything. They did not think the baby was going to live, period. He was born where his intestines were on his outside. So they had to fix that. He didn't have his kidneys were malfunctioning, so they fixed that. But then in the process of doing all of their medical workups, they found that they knew he had a little bit of a heart murmur, but as they worked up, it was not just a murmur. If he did not have a heart transplant, he would not have made it. So the whole team worked to get this child placed with a foster family, and he got his heart transplant, and he is now 2 years old. And he is as happy as he can be. His favorite thing in the world is to jump into mud puddles. That's his favorite. And he's a precious, precious child.
That's amazing.
Yeah.
Thank you for sharing that.
And a lot of times it's just the little things, little tiny steps that they take. Making it through a whole week without having to have medication. It's just depends on the child, depends on the situation. It's what keeps us going.
Well, I have a child on my caseload that I'm staff monitoring, and he was born in Warren County, and he was drug exposed to methamphetamine at birth. He was abandoned at the hospital. He was born with a collapsed lung, and he was life flighted to Vanderbilt, and he survived, and he is thriving. He's a big old 2-year-old. His foster parents adore and love him, and they're about to adopt him. So it's been fun to watch him thrive over the last couple of years. Any last questions, guys?
I have another question, Sarah. Dr.
Yeah, go for it.
Over
here.
What about children who are in full guardianship? For instance, I have a child on my caseload that she's in full guardianship. So for her educational needs to be met, we ask the court to appoint an education surrogate to make sure that somebody is kind of acting in that role. I'm wondering if something like that from the medical side would be necessary, or if decisions like that are left solely to DCS.
Usually decisions are left to us. We have a large, we have a whole policy on consent, who can consent for what and when. If a child is in our permanent guardianship, our full guardianship, then there's certain, is it routine medical care? Is it like a surgical thing, or is it extraordinary medical care? Extraordinary medical care, we like to get a court order. So like a heart transplant, for instance, like if the child had a brain tumor, needed brain surgery, we would ask for a court order on that. But surgeries, sedation, or anesthesia for stuff like that, then the DCS nurse or I will consent for those full guardianship kids, or for kids that are not in full guardianship, but we cannot reach the bio family.
So for example, the removal of all or part of a lung, would that fall under extraordinary medical procedure? Yeah,
I mean, I know what you're talking about. I don't know all the details of her medical issues. From the little bit I do know, I would ask for a court order for that. I think it's safer. It's safer for our agency to be honest.
Thank you.
Now, I will say, when that happens, when we decide, hey, we should have a court order for this, I make sure I tell the DCS attorneys, like, look, you need to have this doctor or that doctor or the other doctor testify, so that the judge who we're asking to make a decision that they often are not equipped to make because they're not medical, but they need to be given the right medical information in order to make the best decision possible.
I work with a child who needs a kidney transplant, and Vanderbilt is not consenting to having the surgery until he achieves permanency. And I think that's in part because of all the aftercare that has to happen. And they want to make sure that this precious kidney is protected and that, you know, everything's happening how it should. Is that a Vanderbilt policy, or is that like a state or national policy? I'm just curious.
A lot of transplant centers across the world, across the country, have somewhat similar policies with various degrees of flexibility. But the key point, there's a shortage of all organs, and no one wants to see an organ go to waste or a child to get transplanted and the organ fails because of neglect. I know which case you're talking about. I've actually had a talk with one of the nephrologists like a year and a half ago. Mary Catherine and I were just talking about that child yesterday. That we are frustrated, very, very frustrated with that situation. I thought the court order would be a great solution, and unfortunately the judge did not. That's a big problem. And there's really nothing we can do about it at the moment. You know, I guess you could have them evaluated at another transplant center, but if they find out why, they will probably say no also.
Is there anything else you think our volunteers should know, like ways that they can be effective in their advocacy for just in any way that you can kind of think of? Like, I know that I work with a volunteer who has a child who has autism, and it's been really challenging to try to get services for that child. And he's worked really hard to try to help grease the wheels on that. And so that just kind of springs to mind. But are there other things you guys can think of that you wish our volunteers knew or did, or anything come to mind?
I would say if you have concerns that the child's not getting the right medical care or enough medical care or anything like that, ask who the DCS nurse is and reach out to the DCS nurse. Mary Catherine, you're okay with that, right? Just
Yes.
Under the bus.
Yeah, they can always reach out to me. My number's on that slide.
Mhm.
I'll make sure they get to who they need to get in contact with. It's probably easier to do that than try
That's
to
true.
figure out what you're doing, but I'll make sure you get to whoever you need to find.
I had a question in the chat, a really
Yes.
important one. Are there any routine things like vaccines, particularly potential controversial vaccines like for COVID or HPV, that would have to be approved by bio parents? How much can foster parents give consent for?
Excellent question, especially in this day and age. And I think we need to be careful about the use of the word controversial. And for all of you guys who are not medical, please understand the HPV vaccine and the COVID vaccines are not medically controversial at all, not even a little tiny bit. Now, we give, when a child comes into custody, the parents sign a consent form allowing DCS to consent for routine medical care for the child. So DCS has long taken the opinion that routine childhood immunizations are considered routine medical care. So foster parents can consent for routine immunizations. When the COVID vaccine became available to youth, we had, you would not believe how many discussions and emails and arguments about this. And the upshot is that it was decided that COVID vaccines, we're considering it, quote, routine medical care. We're not mandating it for our youth in any way, shape, or form. But by saying it's routine medical care, that gives the foster parents the ability to consent for that. We had initially been asking for bio parent consent, but shortly thereafter, this policy was changed to say that we're considering it that something that foster parents can consent to. I have no problem with foster parents consenting to an HPV vaccine either. And I wish all of our kids would get HPV vaccines at the appropriate age. So I just lost my train of thought, but it was good thought, I gotta tell you. Yeah, so the routine childhood immunizations, like the ones you need before starting school, if a bio parent does not want their child immunized, there are certain procedures they have to take for us to say, okay, they have to send us notification that it is, they have a religious objection to it. And I believe that it has to be notarized.
It does. There's an official state form.
Yeah. And a lot of people say, well, you know, when the kid comes to custody, first of all, they're mad at everybody, but they'll say, I don't want my kid immunized. I don't believe in immunizations. That's not enough for us. They can yell at all they want, but if they don't want, we will not immunize their kids if they go through the correct process. And as you can imagine, it's a very, very small number of parents, bio parents, who go through that process of doing that. But again, and since HPV vaccine, I think at this point is not considered a routine immunization, like from a school or from the AAP, it's certainly highly, highly recommended. We let kids and parents and foster parents decide on that. Although I would, man, if I had my choice, I would be shooting everybody in the arm. And I would be throwing, you know, depot shot. Oh, this is recorded. I shouldn't say any of that. I'm sorry. I would never do it. I'm not going to do it. If this gets out, I swear to God, I would never do that. I just believe in keeping kids safe. Honest to goodness.
You're in a safe space. We are nearing the end of our time. Last minute questions, guys. All righty then. Dr. Lowen and Ms. Fortner, thank you so much. This has been so helpful. And I'm going to rewatch this video and take notes and share with everybody. This recording will be available to be sent out for folks who couldn't make it and who want to rewatch it as well. But thank you so much for your time. We have 7 minutes left. If folks want to hang out and just kind of say hi, that'd be great. If you need to go, that's okay too.
Question, I would like to say, I want to say thank you to all of you for doing this work and for representing the kids and being, you know, these kids often need people in their corner so that they know are fighting for them. And, you know, you can never have too many people fighting for you if you're a kid, especially if you're a kid in custody. So I thank you from the bottom of my heart for caring and for doing this work, because I know it's hard. But thank you, thank you, thank you.
Yes, I wholeheartedy agree. Thank you so much. Thank you. Thank you.
And Mary Catherine and I can sign off so you guys can, you know, chat amongst yourselves and stuff. Somebody had a question? Oh.
Yeah, I have one last question, actually, that what you were saying just reminded me. Is there anything that you wish somebody would be advocating more strongly for any of the kids that you know of or see? Like, is there something that you wish people, like an advocate like us, would speak up more about or push more for, or just make sure happens?
I think making sure they get their medical care, but I would also advocate for recognizing trauma symptoms and getting that child counseling. I know it's a lot of work for FSWs, and if they think, oh, the kid's functioning fine, that's great. I'm glad they're functioning fine, but you don't get removed from your parent or your parents and placed in a foster care or residential treatment facility because everything was good.
Right.
It just doesn't happen. These kids are going to carry the trauma with them. It might not show it now, but they will at some point, or it will manifest. So I think being aware, being very trauma informed. If you haven't read the book, The Body Keeps the Score, so Vanderkirk, or the new book, which I have not yet read yet, the Oprah Winfrey wrote it with, what's his name? The guy's name, you know.
Bruce Perry.
That's it. Thank you. Dr. Perry. I knew somebody would know it. You know, that's a little bit more accessible to read than The Body Keeps the Score. But if you're going to do this work, I think read one of those texts, and then you will be more attuned to listening to, oh, the child just got diagnosed with ADD. I wonder if that's a trauma you know, this is from the trauma rather than an innate problem that he was born with. So I just throw that out there as a suggestion.
What was that second book? What is that called?
I can't remember the name, but Oprah Winfrey and Dr. Bruce Perry are the co-authors.
I
Okay.
think it's called What Happened to You.
Yeah, that's it.
Okay.
Got from Miss
Thank you.
Taylor because I thought it was Friday yesterday. I still think it's Friday today. Not. So that shows you how this week has been and why my brain is just not working. It's working. It's just not, working great.
Awesome. Well, thank you again. Appreciate you guys so much for everything you do.
Thank you. Mary Catherine, let's talk on the phone.
If folks want to hang out and say hi, great. If not, that's okay too. If you're feeling extra brave and you want to turn your camera on, that'd be cool too. Yay.
I don't think y'all want me to turn my camera on. I ran in the group this morning. It's
Fair.
rough over here.
Fair. I want to plug something. If you don't have it, it's an app called Libby, and it's through the Nashville Public Library. And that's how I listen to The Body Keeps the Score. You can get free audiobooks and listen to it that way. So if you haven't gotten that, it's pretty life-changing. It was for me when I got it.
I definitely agree with that. I got it in, I think, November after I finished taking boards when I had a lot more free time. And I have listened to so many books because I drive a lot. And it's so good. It's so great. But I also listen to The Body Keeps the Score. And I also listened to The Deepest Well by Nadine Burks, which I thought was really good.
It was awesome. She talks a lot about ACEs in that book. All right. Anybody want to say hi? Want to say something that's making you happy? Something that you're excited about? Doesn't necessarily have to be with your case or CASA stuff. I met a teenager that I'm going to be working with today for the first time, and she's really cool. So I'm excited about that. Sherry?
Sarah, I'm excited to go meet my kid tomorrow, our kid. Super excited.
I'm so excited for you guys to meet too.
My kid is very close to having his case done and being fully adopted. So that is super exciting.
That's amazing.
Yes, TPR is scheduled for next month. So let's just fingers crossed that nothing happens.
We will be crossing our fingers and our toes for you. Megan's talking about condoms over here. Are there any rules around giving condoms to a 14-year-old? Anthony is requesting them. Ew.
I didn't want to put it in the whole group chat, which is why I direct messaged you. But
Oh, I'm sorry. I missed that it was a direct message and I put you on blast. Sorry about that.
Okay. I mean, as a foster parent, thoughts. I mean, it's allowed, right? It's awkward for me. I'm trying to be like very like, the woke, like sexually open foster parent, but it's very uncomfortable for me. And so I'm just,
Yeah.
I think that falls under the prudent parenting guidelines.
Okay.
Yeah, my instincts say, please give this child condoms if they're asking for them.
Okay. Just want to make sure I'm not like DCS isn't going to be like, what are you doing? Okay. Thanks.
Anybody else want to share? Sherry?
I'll share. I have a kiddo who has been in residential. He just turned 13 this past weekend. He's been in residential off and on for a little over 3 years of his life. So that's a huge chunk of this kiddo's life. Mom has struggled to work her plan. At one point earlier this year, we were going down the path of TPR. I don't know if that kind of like was a light bulb moment for mom, but she has gotten her life together, is working her plan, has done everything that DCS has asked her to. She's screening clean, and they had their first in-person visit last weekend for the first time in 2 years. And it's the kiddo who is usually very reserved, and you can imagine a 13-year-old boy usually just very reserved. And when I asked how the visit went, he looked at me and smiled and said, great. And they are going to get to have a extended home pass over the 4th of July holiday. And we are hoping for a trial home visit for him to be back home with mom by the time school starts, so that he can start school with his peers. So I will take that as a win all day long.
That's incredible. Well, guys, we are over time. I'm sorry if you wanted to share if you didn't get to, but I know we all have places to be, things to do. So thank you for coming today. I appreciate all of you and everything you do.
Thanks for having my team, Sarah. This was great.
Any old time. Bye.
Bye.
Guys.